Hi, my name is Vinaya Chong. I'm an orthopedic surgeon in sports medicine, and I practice at Northwestern University Feinberg School of Medicine in downtown Chicago. Welcome to the World Surgery Tour chapter in Sports Medicine Masterclass on Saving the Meniscus. For us, anatomy is of utmost importance. Looking at it from an axial cut here, you can see that the medial tibial eminence and the lateral tibial eminence are of utmost importance as they relate to the posterior medial and posterior lateral attachment of the roots, which will come into play when we talk about root tears. When we consider repairing menisci, vascularity, again, is what we look at here. From the most peripheral area closest to the capsule is the red zone, where it is most vascular. But as we track more towards the center of the plateau here, that vascularity disappears and it becomes red to white red to the white zone. Typically, the red zone are rich again in vasculature, so these are the tears that we always want to repair. However, new evidence is telling us that tears throughout the red-white zone are also reparable, at their healing potential can be quite high. Biomechanically, when we think about what the meniscus does within the knee, we know that it converts the axial forces, the downward force here between the femur and the tibia. That contact pressure is reduced when the meniscus is whole. And so these axial forces are then translated radially and they get absorbed with these circumferential hoop stresses, which is why the meniscus is protective against arthritic change. Here is the agenda going forward, and we're going to start off with talking about horizontal cleavage tears. Horizontal cleavage tears are typically found more in a degenerative setting, less in an acute setting. Ultimately, they're formed more from shear stresses in the meniscus, and sometimes you actually have to uncover a bit of the white zone to reveal the two leaflets seen here and here in the horizontal cleavage tear. When you again think about things biomechanically, this is a landmark paper that looked at cadaveric specimens comparing torn horizontal cleavage tears, repaired states, partial resection where they resected a single leaflet, and then comparing it to a near full resection or a total meniscectomy. And what they found was that even in partial resections, you can see that the contact pressure nearly doubles from an intact state. However, if you repair that horizontal cleavage tear, it is within 15% of that original fully intact meniscus. And so now we know that horizontal cleavage tears can be repaired and also help to protect against arthritis. Several techniques are available to repair these horizontal cleavage tears, and we will demonstrate them in the lab for you today, starting with the inside-out meniscal repair. You can see here, again, the two leaflets of the meniscus, there and there, with the inside-out meniscal repair technique closing that tear of the horizontal cleavage. Of course, with this inside-out meniscal technique, it does require an accessory skin incision, and we'll talk about the different points of the anatomy when we enter the lab. Another way or another technique to repair horizontal cleavage tears is using an all-inside meniscal repair device. These are capsular-based fixation, as you can see here. And again, closing that pita, as I like to call it, so closing the sandwich when you, again, bring it down with this all-inside technique is also another way to repair these horizontal cleavage tears. And then finally, with horizontal cleavage tears for these harder to reach zones, particularly in the anterior horn or in the middle body, as seen in this example here, you can use outside-in meniscal repair techniques, which we will again demonstrate for you in the lab. Next, we will talk about ramp lesions. Meniscal ramp lesions are becoming more and more common, not only because we have now the wherewithal to try to look for them, but also we know in higher level, higher energy types of tears, as in those associated with ACL ruptures, those in younger patients. These are the patients that are more susceptible to these ramp lesions. There are many different classifications for meniscal ramp lesions, and they do vary in terms of location and the different points of the anatomy when we enter the lab. Another way or another technique to repair horizontal cleavage tears is using an all-inside meniscal repair device. These are capsular-based fixation, as you can see here. And again, closing that pita, as I like to call it, so closing the sandwich when you, again, bring it down with this all-inside technique is also another way to repair these horizontal cleavage tears. And then finally, with horizontal cleavage tears for these harder to reach zones, particularly in the anterior horn or in the middle body, as seen in this example here, you can use outside-in meniscal repair techniques, which we will again demonstrate for you in the lab. There and there, with that horizontal cleavage tear, it is within 15% of that original fully intact meniscus. And so now we know that horizontal cleavage tears can be repaired and also help to protect against arthritis. Several techniques are available to repair these horizontal cleavage tears, and we will demonstrate them in the lab for you today, starting with the inside-out meniscal repair. You can see here, again, the two leaflets of the meniscus there and there with the inside-out meniscal repair technique closing that tear of the horizontal cleavage. Of course, with this inside-out meniscal technique, it does require an accessory skin incision, and we'll talk about the different points of the anatomy when we enter the lab. Another way or another technique to repair horizontal cleavage tears is using an all-inside meniscal repair device. These are capsular-based fixation, as you can see here. And again, closing that pita, as I like to call it, so closing the sandwich when you, again, bring it down with this all-inside technique is also another way to repair these horizontal cleavage tears. And then finally, with horizontal cleavage tears for these harder to reach zones, particularly in the anterior horn or in the middle body, as seen in this example here, you can use outside-in meniscal repair techniques, which we will again demonstrate for you in the lab. Next, we will talk about ramp lesions. Meniscal ramp lesions are becoming more and more common, not only because we have now the wherewithal to try to look for them, but also we know in higher level, higher energy types of tears, as in those associated with ACL ruptures, those in younger patients. These are the patients that are more susceptible to these ramp lesions. There are many different classifications for meniscal ramp lesions, and they do vary in terms of location and closeness to the actual capsule and the meniscofemoral or meniscotibial ligaments, as well as if they're more on the superior portion versus more on the inferior portion, or if they are complete. And they are precursors, again, to these bucket handle meniscal tears. Oftentimes, you cannot see these with a normal diagnostic arthroscopy, and sometimes it is required to make an accessory posterior medial portal in order to readily see these types of tears. When you take a look at the MRI, sometimes if you look at the example up here, they're very obvious. These capsular detachments you can see as the white line here on the T2 sagittal image. However, sometimes there are quite subtle findings. Sometimes we only see these bone bruises here and here. And so when you see this on the sagittal plane, always be suspicious to look for these meniscal ramp lesions. Oftentimes, we can also see a little bit of subtle edema here in this posterior medial capsule that can also alert you to, hey, I need to check out to see if this patient has a ramp lesion. Back to the biomechanics, if we think about why it is important to repair meniscal ramp lesions are the protectors, or the posterior horn of the medial meniscus helps protect your ACL. It is the secondary stabilizer. So if you are in there doing an ACL reconstruction and fail to address the meniscal ramp, this puts increased stress on your ACL graft, which we do not want to do. And thus, it increases greater knee A to P translation, as well as rotational laxity. And as we talked about earlier, these ramp lesions are the precursors to full-on bucket handle meniscal tears. So oftentimes, try to find them when you can. And when you do find them, please repair them, as it helps protect the knee and your ACL graft. Techniques into how to repair meniscal ramp lesions. Again, if you're wanting to use this lasso technique, creating an accessory posterior medial portal will be demonstrated in the lab today using this exact same suture lasso technique. However, if you don't want to create a posterior medial portal, it is perfectly fine to do an all-inside technique here. And this will also use different all-inside fixation devices to capture both the capsule below the meniscus as well as the meniscofemoral ligaments above the meniscus without harming the cartilage. My preference for postoperative rehabilitation for horizontal cleavage tears as well as meniscal ramp tears are the same, in that I allow our patients to weight bear as tolerated right away. However, they will be in a hinge knee brace locked in extension. And when that happens, you prevent any of the shear forces by allowing them to still ambulate, but not weight bear and bend. And so this protects your repair for the first 6 weeks. We do allow them to have range of motion to 90 degrees when they are not weight bearing and when they're working with their physical therapist. And they can still manage to activate their quads, their hamstrings, and their glutes during this first 6 weeks' time. If they would like to use blood flow restriction therapy, that's also something that we endorse. After that 6 weeks, they wean out of the hinge knee brace, transition into perhaps a softer knee brace for that first week, and then we discontinue again the brace itself and begin muscle strengthening. Again, this phase 2 for that next 6 weeks after the repair is essential so that limb symmetry becomes close to identical in knee flexion, knee extension, as well as in hip abduction. And then this is an essential part of phase 3. So once the limb symmetry index is greater than 80% and their running mechanics are sound, then we allow them to start impact inline running. And then once again, running and acceleration and deceleration is sound, then we allow them to do cutting, pivoting, and more sports-specific drills. And so it's more of a milestone-based approach rather than a strict timeline in order to get them back to sport. Moving on now to root lesions in the knee. Meniscal root tears are defined as tears within 1 centimeter of the root attachment, and there are various different types that are expressed in the literature, as shown here. Again, very, very important to be able to identify these root tears. Oftentimes in the lateral aspect, the posterolateral root is often overlooked. So this should be a part of your diagnostic arthroscopy as you start off in practice, and even whenever you do a concomitant ACL reconstruction. The anatomy becomes very important in root tears as we want to recreate the exact insertion site of both the posteromedial root attachment, shown here, as well as the posterolateral root attachment, which in fact is just behind or 1.5 millimeters posterior to the lateral tibial eminence and about 4 millimeters medial. And this will be demonstrated in the lab as a very, very important way to get your tunnels in the correct position. If your tunnels are in an incorrect position, then the root will ultimately fail and the biomechanics within the knee will not be restored. So this is extremely important as we move forward. Looking at the MRI of certain root tears, sometimes it is quite obvious if you take a look at the image here on the right. So you can see a total tear between the posterior medial meniscal root that's seen on this coronal plane. My favorite view is the axial cut. So this is often the neglected view of the knee, but it can tell you many, many things, especially if the root here is detached as it is here in this patient. You have heard the ghost sign. This is seen in the T2 sagittal here, where you see a very well delineated anterior horn of the medial meniscus. However, on the lateral side, you don't see anything. It's a ghost. And so this is also a good sign on the MRI for these posterior medial meniscus roots. Meniscal extrusion is a topic that's also quite important, and we know that if the meniscus is extruded more than 3 millimeters, you can also be suspicious of these types of root tears. When we again turn to the biomechanical principle, a root tear is biomechanically equivalent to a total meniscectomy. This has been proven in many cadaveric studies, and you can see in comparison to the intact menisci, which is this gray box here and here, if you do a complete tear of the posteromedial meniscus root, you can see here and here, it is almost the equivalent of a total meniscectomy. However, if it is repaired, you can see that we are able to almost restore the biomechanics to the intact state. So again, important to identify and important to restore the anatomy when it is present. When you look at repair techniques for the meniscal root, it is important if you're doing a transtibial tunnel, you can either do 1 tunnel or 2 tunnels. The most important thing that you should also pay attention to is tunnel conversions, especially if it is in conjunction with an ACL or a PCL reconstruction. In my practice, I have started placing my lateral roots more on the lateral side of the tibial tubercle, and this really avoids tunnel convergence for me, but we will again talk about this shortly in the lab. Here is an example of a posterior lateral root that was repaired in a first of 2-stage ACL revision reconstructions, and then we were able to do, again, a second look arthroscopy during the second stage, and you can see here that the root has been nicely reattached on this lateral side. So they do heal. And then finally, we would like to talk about radial tears. Radial tears are very similar to the biomechanics of a root tear in that the axial load, when converted into more hoop stresses, that hoop stress is now more destroyed after you have this radial tear. And so important to try to come across the radial tear to at least restore, if you can, some of the fibers throughout this red, and the red-white zone. If you aren't able to reconstitute the white zone leaflets, that's okay. But as long as you do the more peripheral sites, then this gives that radial tear an increased chance of healing and restoring the biomechanics within the knee. This is a study here to show that although it is biomechanically close to a root tear, it increases contact pressures much less. So it is much less harmful if you are just to do a partial meniscectomy, for instance, in the white zone, compared to if it is going throughout the entire meniscus all the way to the capsule. These are the ones that are readily repaired across. But if it's just affecting the small area of the white zone, these radial tears can be partially meniscectomized, as they do not biomechanically increase the contact pressures as much as a complete radial tear, which is the equivalent of a root tear. Many techniques have been described to repair these radial tears. We will demonstrate a few of them in the lab today. However, really there's nothing wrong with either capsular-based fixation, all inside techniques and tying knots. The rip stop is something that we mention in the lab, and that we try to use, especially when the meniscal tissue is thin and not as reliable. It prevents you to cut through the meniscus with your sutures. But there are also acceptable techniques that are these more hashtag or X orientation. So as long as you're able to bring that radial tear together, then your repair will be successful. This is an example here of a radial tear in the lateral meniscus with a concomitant ACL rupture as well as a MCL rupture, which we reconstructed both. And you can see here the example of the widened radial tear here in the lateral meniscus using first the rip stop sutures, and then you can see the reduction here, bringing it back together with the repair. Again, we were very lucky that this patient actually had a cyclops lesion that we had to debride, but this allowed us to do a second look arthroscopy to confirm again that lateral meniscus radial tear had healed. My preference for postoperative rehabilitation for root tears and radial tears are very similar and the same, as again, we want to limit the axial load. I make our patients non-weight bearing for the first 6 weeks. They're able to have full range of motion right away when they're non-weight bearing. However, they are to stay on crutches for the first 6 weeks. Following the first 6 weeks, they're now able to weight bear as tolerated. They can discontinue the crutches. And this is when, again, muscle strengthening becomes more important in the quads, in the hamstrings, and in the glutes. Still, within the first 3 months, I do limit squatting beyond 90 degrees to limit more of that shear pressure towards any of the root or radial repairs. And then following this, once again, their limb symmetry index exceeds 80%. That means that they're allowed now to do inline impact running, and then following a comfort level with impact running, we allow them to step to the next milestone of starting sport-specific drills and cutting pivoting. So thank you very much. That was a great overview of the different meniscal tears and how we treat them. And now we will give you surgical demonstrations in the lab. Hi, my name is Vinaya Chong. I'm an orthopedic surgeon.